So we have Malcolm Kendrick, Doctor Extraordinaire, who pretty much agrees with everything I say and vice versa, except a slight difference of opinion on calcium scanning utility. And Dr. Scott Murray, cardiologist, who has a huge amount of experience in imaging and preventative and interventional cardiology. And again, will have his own opinions on calcium scanning. So this is the big discussion. So I thought, well, great to see you again, Malcolm, first of all.
No, thanks.
And Scott, I suppose.
Welcome, thanks.
So anyway, we had a quick chat in the last few days about what structure we'd use, and we reckoned it'd be good to follow the structure of Malcolm's blog because that followed a logical kind of sequence looking at the evidence on various points. And if we have maybe Malcolm just giving his thoughts on each point of evidence or science, and then Scott, you give your opinion, and then at the end, I'll just give my thoughts, maybe refer to a couple of papers that lead me that direction. And then when we've gone through all the points, I think it's 9 or 10 of them, and everyone can make their own decision based on what we say. Then we'll go to part 2, which is, should you get a scan or not? Or who should get a scan?
Yeah.
Yeah. Okie doke. So the first thing is the soft plaque question. So this comes up all the time. And if I had $1 for every time it's brought to my attention or I'm asked about it, I could retire, basically. So soft plaque, how important is it that CAC does not directly visualize or quantify soft plaque specifically? It more quantifies the calcified plaque. How important is that in this overall question of the utility of CAC?
Well, I think it obviously, to an extent, it's key, I suppose, because for people who may be catching for the first time, soft plaque, or I think sometimes called vulnerable plaque, is the plaque that is potentially most likely to cause problems. So some people call it vulnerable because vulnerable plaques can do this thing called rupturing, and that is the trigger for a blood clot that might block your artery completely. So they're the kind of dangerous ones. I know this is taking about 5,000 million bits of information and turning it into a sort of Mickey Mouse-sized bite. But so clearly the part of the problem with the CAC, the calcium scan, is you can't really see these. So the assumption being that if there's the calcified plaques, then that's a sign that there's probably quite a lot of vulnerable plaques in there, and what you're seeing is the end result of vulnerable plaques becoming calcified. The problem is, of course, that you could be doing something that's good, and you might be getting more calcification, which would suggest things are going badly wrong, whereas underlying that, maybe actually the vulnerable plaques are reducing in number. So I think there is a problem here, is are you visualizing, can you visualize the right thing? That's sort of my understanding of it anyway. So over to you.
Okay.
Yeah, completely agree. I mean, I think we've known for some time that the calcium in the plaque is just the tip of the iceberg. It's you know, the fact that it's there at all means that there is going to be other plaque constituents there, and in actual fact, you know, calcification is happening in the plaque anyway, whether it's macrocalcification on a CT scan or not. So you could make the point that, you know, calcification or any plaque there, even non-calcified, that non-calcified plaque is calcifying, and ultimately when that happens, that's where the risk comes in. It's just that in order to try and take one or dip one toe in the bathwater, you need to be able to see this, or at least to recognize that there is a problem going there. What is the phenotype of this person's coronary arteries? Is it a risky phenotype or is it not? And I think that calcium as the tip of the iceberg does give you that information in terms of risk. So it depends on whether we want to know that risk or not, or whether we want to act on that risk, or actually we feel that by acting in some way we are changing the risk. The question is, if someone turns up with a certain score, what stage are they at? And I think that's what we need to drill down to. So yes, soft plaque is important, especially when it's localized with harder plaque or plaque which is calcifying.
So for my thoughts on it, Scott, a paper you brought to my attention, the Scott Hart study published in 2019, it kind of answered the question in a sense single-handedly. And to quote from it, they analysed all the soft plaque in a whole cohort of people. And yeah, to quote from the paper, however, the only independent predictor of risk over the tracking period was the CAC score, a surrogate measure of overall plaque burden. And also, adverse plaques did not provide independent prognostic information where CAC was included. So I think that's the point. The CAC is the tip of the iceberg, at least from my perspective. William Davis, MD, the other day in a discussion on this very thing, he said calcium is an index, a virtual dipstick for total atherosclerotic plaque in all its elements: hard, soft, fibrous, cellular, non-cellular, inflammatory, oxidized, non-oxidized, and so on. So I think for me, the CAC predicts a 20 times risk when high versus low. And it appears that although the soft plaque precipitates many events, because the CAC reflects it so faithfully, its presence, it kind of doesn't matter too much this point. Anyway, so that'd be my thoughts. On the more CAC can be good controversy, and you touched on it there, Scott. So we know, and it's mainly from statin trials, when they realized that statins associated somewhat with higher calcification over a tracking period, there was a lot of energy put into saying that this was probably a good thing, right? Makes sense. And there is some evidence that statin treatment increases calcification. So what would you guys say about this controversy and how important it is in the overall question of whether or not you get a scan?
Oh, speaking personally, your previous points about is there any point in looking for vulnerable plaque as well as calcified plaque, because the calcified plaque gives you a score that is basically what you need, although it's not looking at the actual thing that's causing the problem. I don't disagree with that at all. With regard to, I think the statin one is a bit more, well, you know my views on statins, which are probably shouldn't be described here, but I mean, it struck me as a great irony. It made me laugh when, of course, calcification is terrible. Statins increase calcification. Suddenly, calcification is a good thing. Oh, I wonder why you're saying that. That's the kind of stuff that goes on. But of course, probably the statin one is when you can argue that what you're seeing is more the plaque is actually stabilizing and it's becoming less of a problem. You can argue that. I don't look at the evidence is tricky. This is all the problem with all these things is where's the outcomes, where's the hard outcomes, where can we see it? I think it's probably more interesting when you've got someone who's exercising madly, thinks they're doing a good job, they get a calcium score of whatever, 400, 500, go, oh my God, what can I do? Well, at that point, what you're not going to say to them, well, what you should stop doing immediately is exercising because that's doing your calcification, because
No.
the other evidence is, well, if you exercise, it's good for you overall and reduces your risk of cardiovascular disease. So I think in some people you have this dichotomy of an apparently bad thing is a good thing. So what do you say to these people? I think that's very difficult. I'm not sure what you say to these people, but I think also the other one is, which is important, is a warfarin issue, because warfarin really does significantly increase calcification. Now you're not taking warfarin to prevent atherosclerosis. You're taking warfarin to stop blood clots forming in your heart that then travel around your body and cause chaos. But the reduction in vitamin K, that's how warfarin works. It has a direct, and I can never remember the exact pathway, but you can see that it will increase calcification. So what are you looking at there? And is in this case the calcification a good thing or a bad thing? I've had a lot of people ask me this. I'm taking warfarin, I'm going to have a calcium score. Should I stop taking warfarin, or should I take a vitamin K antagonist? I'm going, I don't know what to advise you on this.
Do you want me to answer that? Or not?
No, that'd be lovely.
I mean, what I'd say is that if you're taking warfarin or non-valvular AF, so you're taking it to prevent, the effects of left atrial thrombosis and embolism, then you shouldn't probably be taking warfarin nowadays. You should probably be taking one of the DOACs or the NOACs or whatever you want to call them, the the anti-10A inhibitors or direct thrombin inhibitors, because the only real people that I have on warfarin now are people who've got either metallic valve replacements or have a clot in the left ventricular apex, or something that hasn't been studied in the NOAC population, because they are non-inferior to warfarin, and they don't have, well, that we know of, we don't have these side effects similar to warfarin in terms of calcification of everything, and you have a better pharmacological response profile, so and less interaction. So I would just say, there is an alternative to warfarin if you're on it and you're worried about vascular calcification and vitamin K as a side effect of the warfarin. So yeah, that was one thing I would say.
Okay, I mean, in answer to that, you haven't spoken to my local CCG. You look at the cost of these new and go, nope. So it might be all very well saying change it, but you might get the local prescribing advisor, at least in the UK, coming in.
I think they probably just need some education on the money they'll save from monitoring everyone's INR and X, Y, and Z. But yeah, there are business cases to try and get around that. So anyway, but that's a separate point from this discussion.
Yeah, so I think, Scott, I saw that NOAC, and there's a couple of papers now, studies on this, where exactly as you say, the NOACs give the beneficial effect, but without driving calcification and causing arguably very negative or deleterious effects. But I guess it'll take a while for that to get into practice.
Well, I think maybe the point Malcolm's making is if you've got a soft vulnerable plaque, you take warfarin, it might calcify, that might be a good thing.
Well,
but we don't know that. It's like the Donald Rumsfeld quote, isn't it? The known knowns, the unknown unknowns. I mean, there's so many different facets to this issue in a particular individual as well. You just don't know exactly what's happening, in such a complex environment. Like your people who exercise. I mean, I've had people on the cath lab table who were, the one guy particularly springs to mind, a good friend of Bradley Wiggins. He's like a massive cyclist all his life, sort of British team, all this sort of stuff, and severely calcified lesion in the ostium of the LAD into the left main stem that needed stenting because of ischemia and breathlessness and chest pain, and really quite severe ischemia in his anterior wall. So I think that just because you exercise doesn't mean that you're going to avoid heart disease. Just the same as if you take statins all your life, you might not avoid heart disease. If you eat like a monk and drink like a monk and you're not an average punter down the chippy every night, doesn't mean you're going to avoid heart disease. And I think that is the problem, is that it boils down to what sort of person you're dealing with and what their values on life are and how they see the world. And I think that's where Malcolm's getting a lot of people contacting him saying, "Oh, I've got calcium, and what does this mean, Malcolm? And I've been reading your blogs, and now they're going to you, Malcolm." And is that where the blog came from? You're fed up listening to people say I've got calcium.
Well, one of the things I do have a disclaimer saying I cannot discuss individual medical treatment with you because I can't and I don't. But I do get these questions back. So, to an extent, the blog I did on calcification was actually triggered by, in fact, was triggered by Gary Towns more than anybody else, who asked me advice on a friend of his who had a very high calcium score and wanted to know what advice I would give. And I thought, well, I'm not going to give him any advice. So I thought what I would do is try and get my thoughts together and do a blog on it. So that is kind of these are my thoughts. They are not a direct answer to anybody's question, but it's to give people further information, and then hopefully they can say, at least they can understand a bit more about the issues. They may come to a different conclusion than I come to about the matter, but hopefully I'm giving people information so they can say, well, at least I understand what it is now. I do understand a bit more about it. It's a question, I would do X anyway, or I wouldn't do X anyway. So I suppose that when you ask that question, my answer is I'm trying to do my best to give people information in a way that they might at least get the information. I sometimes don't put a conclusion down. In this case, I decided I would, which is actually not like me, but I did in this case, and I could hear the coronary arteries clenching in Ireland as I did it. No,
I don't think it was the coronary arteries that were clenching, Malcolm, to be honest. I think it was something else.
There may have been other things, yeah, contracting, shall we say. Okay, well, look, the K2 and the antagonism and the warfarin, they're a little niche, but certainly there are some unknowns there. And I do get asked the question regularly, what if I take K2, which tends towards, lower calcification, possibly a slight regression effect? Will it destabilize the plaque? And for me, I go by the science and everything we do know. We don't know everything. But if you take K2 and you are low in K2, and you improve your health and fix other problems, and your calcification stops or lowers, I think the physiology is smart enough not to regress calcium, leach it back into the system in order to create a susceptibility. But agreed, we don't know. We'll get on to exercise in a moment. That's a specific question. But on the statin increasing calcification, just a couple of points from my perspective. People who take statins, because all of this is associational data, in fairness, it's not RCT, they may be more careless with what they eat and what they do. There could be a confounder there for increased calcification. Also, there are mechanisms statin operates by put forward, like M2 macrophage phenotype promoting, M1 less so. So, does it really matter if statins do increase the calcification a little more and possibly in a beneficial vector? Does it really matter to the question of whether you get a scan to find out your actual level of disease? I guess that's more what I'm getting at.
Well, I think in part the answer to that question is if you're worried about calcification, then the advice would have to be to stop taking statins, because then you'll get less calcification, which is not the advice that the mainstream would come up with. Of course, it's not quite as straightforward as that, but how are you going to advise someone who's then, so you go to a standard cardiologist, you've got calcification, they tell you to take statins because you're at high risk, and that increases the rate of calcification. So how do you then speak to the patient and go, but this is good calcification, not bad calcification? How do you answer that question?
Well,
I can give a stab at that. I think, there is data to say that statins do a whole host of effects, and I think we can slightly just move away from the statin thing, because we, to a certain extent, we could get into an argument of what it does and what it doesn't do. But at the end of the day, if it's increasing calcification within the plaque, I think what you could say is that there is a certain level of calcification where plaque vulnerability becomes at an equipoise or starts to improve and becomes less vulnerable. So there are some studies showing that once you get above a certain level of calcification, that in actual fact, depending on the density of that calcification and the individualized nature of the plaque, it is possible that the risk of that plaque is less. So we're dealing with two separate things here. Someone just gets a calcium score and you don't know how much non-calcified plaque and risky, spotty plaque, etc., they've got. Then if the calcification is at a level where you can do a CT coronary angiogram, which is a move on from just calcium score that we will do in the UK if your calcium score is above 0, and in some cases if your calcium score. But you can then actually see the relationship of the calcium to the vessel wall, to the non-calcified plaque, and to the lumen. Now, often at high levels of calcification, it can be quite difficult to say with certainty exactly what the stenosis in the lumen is, blooming, and effects of calcification on the X-ray ability to look at the lumen. But I think you're getting onto a separate question there, Malcolm, in that if you then have calcification but you do something about it, like you exercise or you're on a statin, if you're going to do a CTA at that point, then you might be able to say, well, in fact, this is a big block of calcium in the LAD that's not obstructing the vessel. It's sitting on top of the vessel. We can see that there's no reduction in the lumen size here. In actual fact, there's no surrounding non-calcified plaque. There's no plaque around there that looks like like high risk plaque, which has like the napkin ring sign. I don't know whether you've heard of that, but that's where there's very low attenuation plaque related next to slightly tougher plaque, and in some cases they can say that you contrast watching in through the vasa vasorum that's actually coming into the plaque. So there's a lot more detail that can be had here to try and say to an individual, look, this looks like your arteries are cemented, and it doesn't look like there's going to be any reason for you to have as high a risk as someone who's got soft plaque next to calcified plaque, if that makes sense. Sorry, there's a baby crying in the background now.
Sorry,
Just woken up.
I'm upset by your discussion of calcification of plaque.
Sorry.
Well, you know what? I'm going to have to be a timekeeper here as well, of course. So we need to move on quite swiftly. But just on that point, I think there's a paper Mike Eade sent to me a couple of years ago. Calcium, or actually, where is it? Under the density. Anyway, I'll put a link in afterwards. I'll put it on the screen. But it goes through the density and volume from the CAC standard scan. So many people just get an Agatston score. But there's some good research which shows that if your density is increasing relative to the volume of calcium, it's a much more stable. So I'll link that paper afterwards. So for people who are into the whole serial scanning and looking at this, which is quite specialized, density and volume will probably be the key, unless they want to go further, like you say, Scott, and get into CTCA and plaque characteristics. But that's kind of downstream of finding out, well, do I have big disease or small?
Yeah. So it comes back around to the Scott Hart thing that, in actual fact, if you could go through all the plaque characteristics, but in the end, you know, calcium, whether if it's spotty and in a plaque, is very important for risk.
And also I might attach a link to, I interviewed Dr. Arthur Agatston, who invented the algorithm for the score, and he goes through this whole topic in great detail with loads of patients' examples and scans. So people are interested, they can really get into it there. So the other one we touched on is the exercise question, which Malcolm brought up, and believe me, I sympathize, Malcolm. I've been pinged again and again since these papers came out. And I think it's association of all-cause and cardiovascular mortality with high levels of physical activity and concurrent CAC scoring. And it was Defina et al. In 2019. But there's some others. Now, what I noted from it is, well, you've got exercise, more exercise people or athletic people may carb up a lot more and drink the sugar drinks. There's a confounder. This is all associational. I know there's some evidence that more exercise, you can drive perhaps more medial calcification and less intimal, unstable. And there's a whole load of reasons for this. But for me, the key thing was that the high exercisers in these studies, with a 0 score, they have, say, a 0.2 rate per 1,000 human years. And with a high score, they have 1.8. So they still have 10 times the risk with a high score versus low. And a high exerciser with a high score is at vastly higher risk than a low exerciser with a low score. So it's kind of like the density thing. It's a nuance, but it doesn't really change the fundamental question about getting a score to assess largely your real risk.
Well, I think to an extent, I mean, yes, clearly that point is there, but if you are an exerciser, you've reduced your risk overall. So if you're a heavy exerciser with a higher CAC scan, then someone's going to say to you, well, what are you going to do now? Do less exercise? Do the same amount of exercise? Stop exercising?
No,
do something different?
Doing the same.
Sorry?
Keep doing the same, because essentially you're training your arteries to be resilient in a way, and that you've developed plaque just like any other person would have developed plaque that didn't exercise. You're actually, sort of, in a way, you're training your plaque to be able to withstand the abuse that you send down your arteries when you exercise, and that your average punter who does nothing but sit on the sofa watching Homes Under the Hammer eating quavers and then decides to go out and shovel snow at Christmas, who then raises his blood pressure and heart rate for the first time and rips off his plaque with that insult, is completely and utterly different from the person who's got arteries that are, trained in a way to deal with that. And so I think you could make the argument that replacing the soft plaque elements with harder plaque is in a way a way of stabilizing or stabilizing the coronary situation. So I wouldn't say stop exercising because you've got a high CAC score. Yes, I would make sure you didn't have asymptomatic ischemia by maybe putting you on a treadmill and seeing what happens. Yes, definitely, especially if the calcium was in the left main or in the proximal LAD, so-called prognostic places. And that would be reassuring for you if you went on a treadmill and showed that you can do 10, 12 minutes without any budge in your ECG or your echo. So I wouldn't tell people with a high CAC stop exercising.
Would as a suggestion, so if you're a high exerciser, so you've got one risk factor pretty good, would the suggestion not be a better focus on all the other risk factors? For instance, find out are you pre-diabetic in spite of your exercise? There's millions of those out there. Or find out do you have heavy metal toxicity or are you low on magnesium? So I suppose for me, if you're high exercise, great job, guy. But the fact is you've developed massive disease. Now, the next question is, it's not lack of exercise. So for me as an engineer, okay, then it's one of the other Pareto items. So what are the other things could have driven it? Let's go, guys. Let's go after those.
Yeah, I think there's an element doing that, whether or not I'm jumping ahead. In fact, I was speaking to my this morning, speaking to my brother and my sister. My brother's an engineer and my sister's did mathematical physics at university. So they both love their numbers and figures. And they're both saying, "Well, I would get a scan. I don't know what you're talking about. You're talking rubbish." So I think that there's an engineering approach to the world which is nice and straightforward and has absolutely nails everything down to a nice reductionist viewpoint. And there is so I think that the issue there of though if you're going to say to someone, okay, fine, exercise is fine, but if your exercise is what else? What if you don't discover the other items? What if they're not to be discoverable? Your risk is still lower through doing exercise than it would be if you didn't do exercise, even if your CAC scan's going up. So this leaves people, I think, with a difficulty, because if you're saying to people essentially, "But don't stop exercising," but you're telling me the exercise is creating CAC, a higher CAC score, it seems to me to be a bit of a conflict there. I'm not quite sure.
I think what's happening is
Sorry,
something else is causing plaque to develop, and potentially the exercise is then changing that plaque morphology, just like the statins would do. That's what I would say. So I would say that it's not definitely the exercise that's causing soft plaque to build up. It might be something else, as Ivor said, but certainly overtraining or doing too much, or pushing the boundaries of what you as an individual should be doing, and that element in your life can certainly, potentially push you on another, path, increase oxidative stress or something else. So I don't know the ins and outs of that. You need to ask someone in exercise, but
I might, just as an analogy, it occurred to me this morning. So exercise is, you could call it a risk factor of sorts or a risk mitigator. And I think what illustrates things nicely, perhaps, there's two papers, and I'll put them up after, on smoking and coronary calcification. And very, very, very interesting. But in one of them, they analysed, tracked over a long period, and they found out that a smoker with a 0 score had 7 times less risk of an event in the following years than a non-smoker with a high score. And in another study, they found out that smokers had 3 times the risk of mortality of non-smokers, but in the same data, the smokers who had a 0 had the same risk of mortality as non-smokers with a 0. So I think similar to exercise, there's all kinds of risk factors, and we know from your blog post and much of what I've put out, there's many drivers, but it doesn't really take from the calcification scan's ability, particularly a first scan, to tell you what the rolled up sum of all the risk factors in your life have led you to. And that's probably for me the biggest value. You actually find the answer regardless of what you did or didn't do in your lifetime, and hopefully gives you impetus to then dig deeper and say, okay, what did I miss? Because I missed something, right?
well, clearly you missed something. You're doing everything you think is right, and you got a CAC score that's through the roof. You're really not doing everything that's right.
Yeah.
By definition, I don't think anyone can argue with that.
Well, in the second half, we'll get into whether you should get one or not, and then we'll get into the actual nuances. But yeah, so the next question is the Maasai, and you raised that, Malcolm, in your post. And I've always been really interested in those Mann et al. Papers about the Maasai. And because of your post, I actually went back to them, had them all on file, and I gleaned a new understanding. So thank you. And when I went back, I realized something. I had always said to people, because anti-low carb and plant-based people point to the Maasai having thick arteries and atherosclerosis. And these are the guys who are eating blood, meat, and milk. So they're kind of saying, oh, look, they got loads of atherosclerosis. But interestingly, when I dug deeper, the Maasai have got quite thick arteries and they have a lot of fibrous plaque, but they have no heart events, or nearly none. And they analysed their arteries every 3 millimeters, all the coronaries, and around 50 hearts, and they found loads of thickening of the intima and fibrous plaque. But they found no calcified plaque. And by inference, reading the paper, they found no necrotic cores, no unstable plaque, and no calcification. And I checked with a couple of pathologist friends. Could they have missed the calcium in someone who would score a couple of hundred in a scan? And they said, absolutely not. So it looks like the Maasai develop a physiologic type plaque, fibrous, maybe like the exercisers, I don't know, but they don't develop the Western style vulnerable plaque with necrotic cores and the subsequent calcification. So what do we think of that, what that means for all of this?
Well, yeah, they always used to annoy me, the Maasai, when I kept reading about them and thinking, well, they've got lots of atherosclerosis. And yeah, apparently they're doing everything that I would suggest is a good thing to do. So what the hell is going on? And I think that, I do think, and I think I said in the blog, I think there used to be a concept of arteriosclerosis and atherosclerosis. Arteriosclerosis is kind of almost a thickening adaptation to exercise, which is possibly a positive thing, because the lumen of the arteries don't narrow; they seem to adapt, so they don't get narrowed arteries.
Yeah, they get leg off.
Yeah, so their plaque. The problem is if you have one word, atherosclerosis, it doesn't actually seem to describe everything that's going on. I read the AHA article series on what is atherosclerosis. Subsection 5, part 4, paragraph 9, atherosclerosis type 7B, subsection C. Like, I have absolutely no idea what you're talking about any longer. I'm giving up. I think they gave up as well, but there are definitely, it appears to be, there are things, a bit like looking at a rash on your skin and saying, that's meningitis, and going, no, not all rashes are meningitis. Some of them are just like a rash. And looking at all arteries and saying that's the same thing, I think is completely ridiculous. So I think my interpretation is that you can get thickenings, you can get what they call lesions, or things that are not absolutely normal, that are actually, they are adaptations possibly to the exercise. It's a bit like going back to what Scott was saying. With exercise, you could be strengthening your arteries up potentially a bit and readying them for life. But so I think I do think that I think there's almost two different forms of atherosclerosis, because as you say, the Maasai didn't seem to have any calcification, but yet other people throw it back and saying, oh, they've got lots of atherosclerosis, and say, I don't think it's atherosclerosis, I think it's a different thing. So I do think that we have to perhaps redefine what we're talking about quite carefully, which is always a problem. So that's my interpretation.
I think that's entirely right. I think there's not just one atherosclerosis. I think it's a multitude of potential outcomes within that particular plaque, and it might change all the way down a coronary artery. So you can see one plaque which is calcified and there's nothing else there, and then a bit further down you'll see one that looks more vulnerable, and that's the issue with the atherosclerosis and vulnerable plaque theories, and one of the reasons why I stopped doing the hunt for the vulnerable plaque, because when you do an IVUS or an OCT on a coronary artery, you just find that it's everywhere, and that's the thing. So you can't just say, oh, there's a vulnerable plaque there, because there's one, 2 centimeters further down. You won't see that on an angiogram, and that's one of the difficulties we've had in the past in cardiology. Everyone's just gone and had an invasive angiogram. Now, you will see that on a CT and the proximal coronaries, which is the most important thing. So I think definitely there are different phenotypes in terms of how an individual in a particular environment, or the combination of genome, proteome, metabolome, all those things with their exposome. So I'm sure if you took the Maasai and dropped them off in Wishaw, where I grew up, that the Maasai wouldn't last very long, because they'd be at the chippy every lunchtime, and they'll sit drinking iron brew. So, it depends on individuals, and there's definitely not just one arteriosclerosis, there's multiple phenotypes.
Well, absolutely. I agree with both of you there. Agreeing with two Scotsmen, Janie. That's it. No,
well, I always told always be wary when an Irishman agrees with you. Ivor. You're in trouble.
There's some ulterior thing going on, but in this case, it's perfectly above board. No, I agree totally. And the Maasai actually, like I say, new insights there, because I had never realized they had apparently no calcification. But then the Semaine people have no heart attacks in Bolivia, and they have effectively no calcification even in their 70s. Now, I'm not sure about their thickening, and Katavan similarly. So for me, the calcification is the big flag, not just of some form of arteriosclerosis, but it's a flag of modern inflammatory atherosclerosis, quite specifically. And there's something huge in that, which I have to think about some more. But these indigenous populations, interestingly, Mann and his team in 1972, who did the autopsy on the Maasai, they actually called out the root cause in their mind. And they were surprisingly accurate. Exact same as Weston Price. In their mind, it was a dietary component which was as yet not identified, but they took a shot at sugars, refined grains, and vegetable fats, which were beginning to be introduced into the country. And Weston Price, likewise, he pulled it out as sugars, refined grains, and vegetable shortenings, which he saw the city people from the same tribe who were getting their teeth rotting, hypertension as they aged, and all these degenerative diseases. And then their cousins, same genetics, back in the forest, were not. And he picked the three same things. So that's just an interesting sideline. No proof, but it's funny how we all come back to those three things as real biggies.
Maybe someone you should talk to is a guy called Paul Marovich Horvat, who works out of Budapest, and he worked with Udo Hoffman in the States, and they coined the term napkin ring plaque on CT as a vulnerable plaque. And he's a fantastic guy, and he's got identical twin studies who separated at birth or lived in different environments. And I did publish a case of identical twins, one who'd had an acute coronary syndrome and one who hadn't, but had a similar plaque developing. And one of the guys was a runner, but that's available online. I can probably give you that to upload with the transcript. But what he showed was that, interestingly, if you put the CTs of these individuals side by side, you've got very similar coronary architecture in terms of bifurcation, side branches, because the angle of the bifurcation can matter in terms of the shear stress that comes at particular areas. But what was noted was that the twin who grew up in quite a difficult environment compared to the other in terms of socio-economic deprivation, the coronaries were starting to develop an element of tortuosity. So good twin, if I can call them good and bad twin, good twin had straight coronaries with bifurcations. The twin who actually had metabolic syndrome, hypertension, other risk factors developed from their exposome, had an artery which was starting to bend because of hypertension. It's one of the issues with hypertension, and also microvascular obstruction. So if you've got microvascular disease, there's a back pressure up the coronary, and also you've got hypertension coming down, your coronary starts to bend. If you start to create bends in the coronaries, you start to create more low shear stress areas. So that is where the plaque was developing in the bad twin. if I can say bad twin. But you should probably get Paul Moravich-Horvat on to show you those images and to explain more.
That's
Will do,
interesting,
Scott.
Unaware of that. That's interesting.
Well, that ties, Malcolm. You've talked extensively about this, of course, endothelium, low shear, nitric oxide. So in fairness, these are all the things we fully agree with, but I hadn't quite realized that example, Scott. So I'll connect that in afterwards and maybe catch up with that guy. So again, I'm conscious there's all kinds of rugby and sport going on, so I keep moving. if
Scotland and Ireland have played, have they not?
Yeah, they did.
I know nothing
he was
about
uninterested. Ireland won, luckily, against the plucky, skillful Scots.
Good defence. Good defence.
We'll get through all of these, and then we'll get to the really important second part. So if a person's CAC score is shooting up, Malcolm, you said in the blog, and there's evidence of diabetes, dysfunction, smoking, steroid use, air pollution, etc., and you have a long list, then you need to take action on behalf of any of all of these, and more, I would say. Does this suggest CAC is actually very useful to know for someone who's willing to tackle and take care of the root causes?
Yeah, well, I think, in fact, my concerns about screening and scanning almost date back to reading Bernard Lone, who I'm not sure if you've heard of him.
Oh, I know.
Fantastic man. I think he's still alive at 90-something. And it first started when he was looking at angiograms when they came in, and they used to do scans on people, angiograms, and if they found a obstruction in the left anterior descending, they would call it a widow maker, and then said, "Do you want to have something done about it or not?" And the answer was, "Yeah, of course I want something done about it." So he was concerned. He'd seen people having these scans who then ended up with embolisms, having strokes and things like this. So we realized that there was some quite serious downsides to having the scan, which is not the case with CAC. But then he tried to do a study where he looked at people who got this blockage and tried to find out whether it'd be better just having medical treatment or whether they wanted a coronary artery bypass graft. And of course, he couldn't get anyone involved in the study because the moment anyone saw this widowmaker, they wanted an operation. And then he then went back and tried to, what he managed to do through ECG tracings, etc., was to define whether or not somebody had what would be a widowmaker without doing the angiogram. So he managed to get enough people in his study to prove, as he saw it, that actually medical treatment was just as effective in many cases, or most cases, or I can't remember the exact details, as having the coronary artery bypass graft. So he couldn't get that published for 4 years because obviously people were making vast sums of money out of doing coronary artery bypass grafting. And I think we can see the same thing in a lot of cardiovascular interventions is takes you back to what good did this do? You know, screening and scanning can often have negative connotations. You do, say, for instance, prostate cancer screening, you find you've got prostate cancer, low grade, what do? Well, actually, it's probably better to do nothing. So the primary problem I have with screening and scanning is always this one of, if your investigation is not going to change your treatment, why are you doing the investigation? If you know what the treatment is, you know what to say to people. You know, lower this, don't smoke, take a certain amount of exercise. We think all the things that are beneficial. I suggest that we don't really know all the things that are beneficial, but we're going to advise people. What advice do we give people? Does it change your advice? Would it change your advice to people significantly? Because there is always a downside to scanning and screening as well, and it can scare the living bejesus out of people. And I've seen a lot of people, I get a lot of emails, I've had a CAC scan, it's high, oh my God, I'm going to die of heart disease, virtually. Now, if we could then say, well, don't worry, I have an intervention, it's guaranteed to make things better, and we had such an intervention, I'd say, well, that's fine, now we can do X because we can sort it out. But at the moment, I think we're not clear enough about the interventions that will improve the outcomes sufficiently to justify having a lot of people being worried that the anxiety levels can be very high. So for me at the moment, it's, you know, these things are a balance. Some people, robust people, engineers, they'll go and get a scan and say, right, I shall do X, Y, Z, this will be beneficial, I'm fine, I'm going to carry on, da-da-da-da-da. But I see the fallout of a lot of people going, oh my God, you know, and the oh my God people have to be balanced against the benefit people. And to my mind at the moment, and I can be convinced the other way, I see the downsides as outweighing benefits. Not enormously, like any scanning program, there's always benefits, there's always downsides. And you have to look at these things quite carefully and do them. So if anyone wants to say, if anyone said, I want to get one, I want to get a CA scan because I want to know exactly what's going on because I want to sort it out, there's no way I'm going to say, well, just don't be an idiot. I would say, well, you have to remember that, what are you going to do? So it's a nuanced area, but I still think it's like I would never tell anyone to get a PSA score to find out if they got prostate cancer, because it's a rubbish screening test, because the specificity is rubbish, and therefore we're giving a lot of people concerns and worries when they don't need it. So that's kind of the background philosophy to it, if you like, and that becomes an issue of, as you say, have we got the data to say these things for sure? These are difficult things to analyze. Anyway, I'll shut up now.
What I was going to say was that, yeah, I think if people, let's take the example, someone decides to get a CAC score and gets a positive result, I think that, they should be, if they're extremely concerned about it or they don't understand, then they shouldn't be emailing you. You should be going to the GP and come and see a cardiologist, because there are things that we can do to, really drill down a bit further so that they can regain confidence acquired in their particular phenotype. And I think this is the point, is that if someone wants to know, and your point's well made about different people maybe aren't prepared for that, and I think there's a really good framework for that called the Healthy Foundation's life stage segmentation. It actually tells you what you are in terms of, I think there's 5 different people now. I know I'm a balanced compensator with a bit of healthy realism. There, in Liverpool in particular, there's 50% unconfident fatalists. So if you give them that information, then they can't deal with that. They don't have the health literacy. And health is maybe number 6 or 7 on their list of priorities. And then you've got people who are like hedonistic immortals and live for today's. So, it depends on where you are on your life stage segmentation, on how you can then deal with that issue, like you said about engineers just going away and finding a root cause. But if you know where you're at, and then you're worried about it, then you should really be in front of a cardiologist who says, well, how high is the score? Well, let's see, have you have any symptoms? Where are you up to? If you're completely asymptomatic, then the next stage is to consider actually trying to make you symptomatic. Because a lot of people say, oh, I've got no symptoms at all, so what do you do? Oh, occasionally go up the stairs once a night to go to bed. Well, you're definitely asymptomatic. I guarantee someone who's asymptomatic, I could make them symptomatic. And I would be able to know whether they've got a significant amount of ischemia affecting their heart muscle by simply putting them on a treadmill or doing a debutamine stress echo, which could unmask asymptomatic, if you put the asymptomatic in inverted commas, ischemia. And ischemia is just a surrogate of plaque burden in the end. Plaque burden is covered by calcium scoring. So if you look at the paradigm that calcium scoring tells you a surrogate of total plaque burden, and total plaque burden gives you a surrogate of ischemia, and ischemia is what eventually will give you symptoms or give you risk, then I think there's a way of walking back through that by stressing someone or going on to do further tests. But even then, I shared yesterday a case report we did from our group, someone who had a CT scan for another reason, but actually when you look at that scan post event, you see that there's a plaque in the middle of the LAD, and they went on and had a stress test which did show a couple of little areas of lack of blood supply, but they were just placed on standard medical treatment, aspirin, statin at that point. But 15 months later, after a knee operation, they had an event. So that plaque was responsible for it, and it was shown on the subsequent angiogram. So I think that there are a few things we just need to work through here, that people should not just be emailing Malcolm Kendrick if they've got a calcium. It's positive.
They won't get any answer from me anyway.
And GPs may see an influx of people who've had calcium scans, and they'll be like, oh, I don't know what to do with this. the point then would be refer to a cardiologist, and then hopefully we can bring cardiologists up to speed with what they should be saying, rather than you going in the cath lab and I'm going to stent the bugger, because that's not right either.
But this is a very fair point, and actually, in fairness, Irish Heart Disease Awareness, I work on behalf of, and David Bobbitt, he funded the Widowmaker movie, $2 million, and it says exactly this. It's the story of the stent not changing outcomes. And we have the Courage trial and the Orbita trial more recently, and even now sham trials for those sham surgeries where the stent doesn't even seem to greatly impact in many patients' symptoms.
So there's a caveat to that, though, Ivor. I will stand up for the interventional guys to a certain extent. There's a ischemia trial which has just been released. It shows that if you do have a left main or a proximal LAD stenosis and there is significant ischemia there in the ventricle, and you've got X, Y, and Z other risk factors, and that has been, there are techniques such as pressure wire to measure the reduction in flow. If you have got a really sort of narrow stenotic plaque there, that, revascularization of that does prevent late myocardial infarction from that. So there's a balance there, because it could just stimulate collateral supply, and you could get this really great collateralization of the heart, which means that you remain asymptomatic, and that lesion doesn't really matter, and that's why doing nothing sometimes helps. But if you've got disease in the artery that's collateralizing it, and you don't have very good collaterals because you're diabetic, then you're onto a loser there, because when that plaque goes and you can't cross fill it from your other arteries, you're a goner. So I think that's why you do need to investigate people further.
Yeah.
I have somebody who's a regular on my blog who's got no patent coronary arteries.
Yeah.
Hasn't had for 15 years. Lives in Sweden. And in fact, my father-in-law, although he did die, and he had no patent coronary arteries, and used to go to the cardio rehab gym and stuff like that. He couldn't do a huge amount. So I think that to me, what a concern out, which I haven't raised, is more that, as you say, we need to educate our fellow cardiologists as what to do. Is that the problem we have? The most people getting a CAC scan at the moment and getting a high result will be going to people who may not, in my opinion, be necessarily giving them terrifically good advice about what to do. Like, you need to stop eating fat and eat more carbohydrates, and take a statin, and blah blah blah. And I'm thinking, you know what? I'm not entirely in agreement with this philosophy of what you're saying, and therefore, there's another aspect there which I didn't really raise in the article, but it's partly, I can hardly stand back. I mean, I get enough accused of being enough of a maverick without saying, don't go to a cardiologist, they don't know what they're talking about. But because previously you would have probably had someone stick a stent in you, and
you don't want that,
or whatever. So a lot of interventions. So it's this thing of, if you're going to do a scan or a test or any sort of screening, or then you have to be very clear about what the pathophysiology of the disease is. What exactly is it, and what interventions then work? What interventions are effective? Because, like with screening, I would say, well, if it picks up disease early, and it's 100% sensitive and 100% specific, and you then act, and that when you act, you are going to definitely provide benefit, and that will be seen in outcomes, then who can object to that? Well, nobody. Well, I wouldn't object to that, but maybe somebody else would. But at the moment, I think there's a little bit, there's gaps, just a few too many gaps. Is where I see it myself personally.
Now, Malcolm will agree on that, and certainly David and myself have discussed this, and we always say it's a two-hander. You've got to get the information out, the right to know about the calcium scan, and I might pop up a couple of studies here which blew me away years ago. Nasir et al. 2016 and Budoff in 2012, and you see 0, 1, 2, 3 or more risk factors versus a calcium score prediction of risk, and the graph will just blow you away. So I guess we'd agree that the calcium scan has enormous ability to tell you your risk. But then this question of what happens to you. Now, if a guy or gal gets a high score because they found out about it, let's say for non-arrogant purposes from me, they'll get a lot about the root causes, about William Davis, MD, the cardiologist, who has stopped progression in countless patients and almost eliminated secondary heart attacks or primary ones in his patient population. And we know all the root causes you went through and I go through. So the person who finds out about the calcium scan and all of the stuff they need to do is without question, I would say, going to dramatically lower their risk from that day or week onwards. The other extreme is someone who wanders in willy-nilly, gets a scan, and the doctor's clueless and just gets a med. Now, you could argue that someone with a high score from recent studies, a high-scoring CAC statin can show, and you've acknowledged yourself, Malcolm, it has a benefit. Well, in someone with a high score, it's actually pretty good benefit, so at least they get that. And in someone with a low score, it's no benefit. In fact, it's harm. So calcification then at least would give the person who does not know anything with a clueless doctor, it'd give them something, something. But I think for me, the real focus is because the calcium scan tells you vastly more than the risk factors, it's a no-brainer if you want to know and take action to at least get a proper test. Because the risk factors, I mean, they're so misleading. It's quite shocking.
I think there's the other thing, sorry to interrupt, but we focus, and there's a John Manrola article as well, which focuses on the anxiety created by getting a positive score. But what about the 50 to 60% of people who get a negative score? They're now breathing a sigh of relief, having gone in worrying, oh my God, I've got, high cholesterol, or I've got a family history of heart attack. And in actual fact, now I've just realized that my actual chance of a heart attack is less than 0.5% per year. And that, even up to 13 years of follow-up in a London cohort, and some of the stuff that Karim Nazir's, done with Michael Blaha and Tal, etc. You're showing that no one died of cardiovascular death up to 13 years. So, I think we're focusing on the people who get the positive scores, but in actual fact, you get a negative score, it's good news for you.
Well, interestingly on that, and the stuff's really coming out of the woodwork now, is the power of zero is the hashtag, and Karim Nazir is doing incredible work. But his latest paper out a few days ago is very high LDL levels. The power of zero works here too. And he makes the absolutely appropriate point that high LDL in the new guidelines now, above 190, is automatic medication for life. And that's based on the West of Scotland WASCOP study. And don't get me started on that. It's outrageous.
Yeah. But it's my fault.
Scottish. You guys. But the point is...
My grandfather was in that, actually. He took pravastatin, yeah. He was in it.
Wow. Well, long story short, they basically... The only data they had from that you could call in any way credible to justify 190 or above automatic medication for life is WASCOPs. And the thing is, that was mostly diabetic men. And they're applying the rule to non-diabetic men and women with the new guidelines. So that's a problem. But Curran pointed out in his latest paper, and again, I'll link this on the screen, that high LDL people, super high, 40+% of them have calcium zero as well. So you've got all these people scared about LDL and cholesterol and myriad other things around the world. And the calcium scan can actually tell them the truth in a huge number of circumstances. Now, we've got a...
Why interrupt? I think I agree that you may be unaware there was a study done in Nottingham, I think, where they actually looked at 48 factors with regard to what the actual risk of heart disease was, and LDL came 46 out of 48. Only two things below that was FEV1 and the ALT.
We've got a drug for that, Malcolm. We've got a drug for that.
You got a drug for that. Yeah.
We've got a drug for that, and we will soon have drugs for triglyceride to HDL, and lowering triglyceride and lowering LPA, and we'll have, I'm being facetious, but it is driven by the fact that there's a drug for that, not that there's a lifestyle for that or a.
No, absolutely. I think if I may make a general point, is that the risk calculators are rubbish. More than rubbish, completely rubbish. Our understanding of the risk factors, the mainstream understanding of the risk factors, is poor. So if one was to say every screening test becomes valuable if the interventions that are based on that are effective and are good at altering the results. So one of my main things, yes, if you did the scan, Ivor, and then send it to Scott, and you discuss these things with patients, I think the outcomes would be positive. But the problem I have at the moment is that we're relying on outdated ideas about what is actually going to create benefit and what people are doing. And in that world, this is the world in which we are in. All right. If it was a perfect world of, we analyze people, we tell them what we're looking for, we see a scan, the negative ones are reassured and everything's fine. The positive ones we can do something about. Again, I couldn't object to this, but I don't think we're in that world at the moment. So that's why I'm advising against it for people. But in the right hands, I think these are, as I say, we're not talking absolutes. These are gradations of benefit versus harm. At the moment, we need more people to do this stuff properly, and then we can create outcomes upon which we can say and look at these results. So I don't know if that's clear or not, but that's kind of where we are.
Yeah, I can agree with that.
And well, yeah, it is a challenge, or as I said, a two-hander. Both things have to be fixed, and they both have to move forward in parallel. In my mind, I mean, that's the way we always do it. You don't wait to replace crappy risk algorithms and risk factors with a proper scan or a proper diagnosis until everything's all lined up. But I agree, of course, the whole medical business, there's a lot of challenges and a lot to do, but we at least can get the risk measurement correct, and then with time, hopefully the other will improve. Raji et al. Had a study there, which I often quote, and basically on a group of people all on statins, so they were all medicated, blah, blah, blah. The people who progressed at a high rate in calcification had 17 times the event rate in Kaplan-Meier as the people who had the same very high score, but they didn't progress. They were slow progressors. And just to give an indication of what might be possible, let's just take magnesium, which I know, Malcolm, you think could be a significant thing, magnesium deficiency. So a very recent study, and it was an RCT in humans with chronic kidney disease, and basically they had diabetes type 2 and hypertension, the usual risk factors, so the very people we'd be concerned about. And for 2 years, they gave one group magnesium oxide, fairly high dose, and the other group were control, nothing. And the former group at magnesium oxide, they got 11% progression on average, and only 22% were above 15% progression per annum, right? Now that, as per Raji and other progression studies, that means relatively super safety. And guess what? The people in the control group without the magnesium, they were an average of nearly 40% progression, and 65%, I think, of them were over 15% per year, which is kind of the magic number. So that just kind of looks at magnesium sufficiency. But we know there's a list of probably 6 to 10 major drivers of heart disease. Imagine what you can do when you find out you've got an issue. It's huge. And the people who can be saved are the people I think we're really thinking about. Not so much the people who are going to worry. You could argue that the people who are just going to worry and aren't up for doing what needs to be done, you could argue, why did they get one in the first place, perhaps?
Oh yeah, no. I mean, as I say, if your interventions are going to be beneficial, it's the problem at the moment is primarily a lot of the interventions that are going to be triggered by this on the mainstream, in my opinion, are not going to be beneficial. We're going to be telling people to do things that are not necessarily going to alter their risk factor, because, as I said, if the risk calculators and our perceived key risk factors are wrong, then we're really not going to achieve a great deal of benefits. It's just, I was speaking to someone in America. His LDL level has been 18.5 for the last 30 years. He has no detectable atherosclerotic plaque or calcium, and so people telling the most people will then be immediately placed on medications, lots of medications, many medications for the rest of their lives. This is the reality of what's going to happen in the world. Yes, if someone in the right position who understands what's going on, then I think we can see significant benefits. But my concern at the moment is our interventions may do more harm than good in many cases, or we're not looking at the correct interventions. So therefore, that's really where I'm coming from. And to an extent, I wasn't hoping there would be a debate in this. Hopefully this will trigger a wider debate of some sort, and people will be interested in the area, which is that we need to be looking more closely about the things that we should be doing with evidence that they benefit. As you're saying, your study on magnesium, well, that's fantastic. You know, what about potassium? You know, potassium is another one. What about et cetera, et cetera? Be nice to see more of this data that we can then say, right, well, we now have an intervention that we can say is liable to be extremely beneficial, and we have data to demonstrate that. And once those things happen, obviously the shifts towards, yep, let's do this thing. If that makes sense.
Right. Well, actually, yeah, it is a huge point. And I read that in your blog that, you know, not so much that we don't know, but orthodoxy perhaps does not know all the really important stuff that should be focused on. Therefore, you lose a lot of the benefit for someone who walks in clueless and meets with clueless people in the business. But again, Davis, though, is kind of given the proof point. I mean, his study on 45 people over 34 months, he went in with fish oil, vitamin D, low carb, magnesium, and he achieved 42 out of the 45 to have regression or no movement or slow progression in the following 34 months, which is groundbreaking. Now, of course, Malcolm, I agree. The problem is no one's reading his paper. But I mean, the proof points are there. And I had one other thought, and Scott or Malcolm, you might tell me what you think. Whatever about, okay, we mentioned magnesium, and there is a trial on that. We're lacking trials in all of the other stuff we know is important. We pretty much know. But if you take, for instance, diabetes type 2 dysfunction, that's a huge driver. And the EuroAspire study recently, CAD victims ages 18 to 80, 26 countries across Europe, and 76% were essentially type 2 diabetic, most of whom were undiagnosed before they looked. And the others, they didn't measure the insulin. So we know that most heart disease victims are essentially diabetic, along with other problems. But we also know from Virta and many others that we can intervene when we know there's a problem and largely resolve the type 2 diabetes dysfunction. So that alone, if the calcium scan identified you've major disease and you check and find out about postprandial glucose and glucometers, and like David Bobbitt did, he went digging and he found out some of this, and he found out he was a screaming type 2 diabetic, undiagnosed. So that alone, if we start identifying all the people with undiagnosed diabetes and they find out, which we are finding out, that it's resolvable, though not with orthodox methods or drugs, but with other interventions, that's huge. That's huge amounts of lives that could be saved, you know? What do you think of that one?
If I might just jump in, yes, again, the problem is that you're you, and you're one person, and outside of this discussion, perhaps, or a smaller group of people, this whole diabetes, high sugar level issue is just not recognized like that. It's just not recognized like that. And therefore, you're not going to find your average doctor or your average cardiologist dealing with it in that way. It's not going to happen at the moment.
I think if they do deal with it, it's going to be by prescribing an SGLT2 inhibitor so that you pee out more sugar. And I think the problem goes back to your individuals, Ivor, because you know not everyone can take vitamin A2 and magnesium and vitamin D, and then you know sort the lifestyle out. You find your average punter still going down the pub for 6 pints, nailing a pizza on the way back. I know I did on Friday night. So you know. There are like utopias and dreams and if everything was absolutely perfect in an ideal world, we'd turn around tomorrow and you know Trump would tweet to his 50 million followers or whatever, oh guys, you better watch out for your postprandial glycemia, you know, and or you know people would start wearing CGMs, or Kim Kardashian will put a CGM on and Instagram, and instantly everyone will be worried about what the postprandial glucose is and you know how to stabilize their you know metabolic profile. But that's not going to happen because people are people, and it filters back to this life stage segmentation thing, because I think you will always have your healthy users, you know, your vegans, vegetarians, people who are concerned with exercise, blah blah blah, healthy user bias, and well, perceived healthy user bias. And then you'll always have your working class man who just wants to go to the pub, have a fish supper and put a bet on. So, you're not going to, changing those people is very, very difficult.
So, if you were harsh about it, Scott, and Malcolm indeed, you could say, well, there's a huge amount of people out there, millions, if they found out that they had major disease and they've been lied to about vegetable oils and complex carbs and all that, and were willing to go and dig, that could save themselves. But equally, there's a huge amount of people who will not do anything, who don't care. And you could say, well, okay, we're not as worried about them. It's a fair point. We're only worried about the people who will actually take the responsibility for their health and act on finding out they have a major issue and that they were essentially lied to about how to prevent such an issue, largely. So that cohort is where I'm focused.
Yeah.
And again,
well, you're being a bit negative. We'll call them early adopters, and then so
You're going to put Darwin. You're going to put Darwin on. You're going to put Darwin.
No, early adopters. That's a marketing thing. Early adopters, and then whatever it is. There's some people who will buy the latest hi-fi equipment, which costs £5,000, and then in about 6 months it'll cost about 20 quid. And so there's always people who will be at the front of the curve. The majority sit somewhere in the middle, and there's some people who will never change no matter what. And so you need the early adoption. So some people, things will change slowly. I'm going just for saying to you, Ivor, and I hate to jump into the thing at the moment, but I'm going to have to say I'm going to have to go in about 2 minutes. So it's been a fantastic discussion. I think I've learned a bit myself here. So my learning would be, that we can always listen to each other and exchange views. And I think I'm delighted that we've had this, I think, civilized discussion about this and shared views. And hopefully, I think we're all mostly on the same page about most things still. And in almost everywhere we're agreeing madly. But I think my concern is in the world as we have it now. I'm a bit worried about people going off and CAC scanning and then not being dealt with correctly. If that world changes, the dynamic changes, and the balance of benefit to harm changes as well. But I'm not anti-scanning per se, as you know, as we've obviously discussed. So I think I'm not sure if that's my final word on the matter.
I think you have to say that it should never happen that someone gets a CAC score and then they go straight into a cath lab. And this is in the States. That should not be a reason for an interventional cardiologist to make money from your arteries. You need to know, and in the UK, what would happen is they would either have a CTCA to see whether we can actually see whether there's any flow limiting disease or the combination of hard and soft plaque. We could even potentially do CEFFR to look whether there's ischemia there. But even that is a bit difficult around the boundaries you need it to be, but it can rule out definitely ischemic to non-ischemic. And then you should be having some form of stress test to reassure you. You should be seeing a cardiologist. You should be, encouraged to adopt new lifestyle changes, but you should certainly not be getting put in a cath lab, because I've heard bad stories about that. So that's what I would probably, I think, appease with Malcolm's opinion on this, that it should be used, their tactic, it should be used as a individualized way to recognize your current coronary phenotype rather than a blanket screening thing. It should be for the person who needs it.
And I guess what I'd say, though we might do another little segment to fully close this out, but my thoughts on it would be that we need to give the power back to the patient to take personal responsibility. I'd be focused most on the people who are willing to do that and can do that. The ones who are not, they'll at least get some medications, or they maybe go through the process, Scott, as you said, to get proper follow-up and proper treatment appropriate as opposed to the bad stuff. And really, the right to know for me is that you have a right to know that there is a scan that can actually tell you properly compared to all those junk risk factors. You have a right to know about the scan and to make your own decision. And if you walk willy-nilly in and don't know what you're doing, okay, that can create worry. But what I'm seeing are a growing army of people who are finding high scores and are up for it and okay with it. And they're taking action. And we know there's so much action that can be taken. So I think that's where I would focus more on, that everyone knows about it and has a choice. And right now, no one knows about it. And one last thing, actually, Malcolm, to your point, the early adopters, and I know there's that marketing curve with the chasm, the early adopters who go out there and find out all the untruths we've been told and who take action and research, they can become very vocal and they can become very influential also. So I think it behooves us to get the message out on the scan and the root causes and create a growing army of people who are now aware. And they will ultimately change all of the bad things about the system we're talking about. But unless we get it out there, we'll be left with all the bad things, I guess, Malcolm, that you refer to. Very good.
This is the point where you put in the, is it A Few Good Men, Jack Nicholson and Tom Cruise, when he says, you can't handle the truth? Is that what you're going to put that video in there?
That's exactly it. If people can't...
It's a bit where I put in Einstein saying there's only two things that are infinite, the universe and human stupidity. And I'm not so sure about the universe.
Well, the universe is made up of protons, neutrons and morons, is that right?
That's right.
Okay, well, at least we're none of us three by any means are in the latter category. That's for sure. We're very well aware. Hey, thanks a lot, guys, and we might circle back for a quick 30 minutes if necessary to add into this, or we'll call that discussed.
Thanks very much.
Thank you.
Thanks, Malcolm.
Thanks, guys. Thanks.
Cheers, Ivor.